So patient comes in, has signs and symptoms of hypercortisolism, buffalo etc., weight gain, central adiposities, fryer, blah blah blah. So we're gonna do low dose Dexa suppression test. If you do low dose Dexa suppression test and ACTH is suppressed, ACTH goes down, cortisol level goes down. This is pseudo Cushingism. Like patient doesn't have true, they don't have a pathology because the axis is responding right to Dexa, which is cortisol. So Dexa, low dose Dexa is able to suppress ACTH, able to suppress cortisol, able to suppress CRH. This patient just has physiologic, right? It's something that is mimicking hypercortisolism, right? But it's not true hypercortisolism. Yeah, so in that case, you're dealing with maybe the patient just has maybe patient might be obese, they might have acromegaly, they might have something else that will mimic, just mimicking. So in this case, we do nothing, right? We're done. But if you do the low dose Dexa suppression test, so I zoomed out on the page to make it smaller. So if we do the low dose Dexa suppression and these guys, cortisol is still high, which means the axis is not suppressed. Cortisol is still high, the axis is not suppressed, then you're dealing with true Cushingism. The patient truly has something, a pathology causing, right? Hypercortisolism. That's why the axis was not suppressed, right? By low dose Dexa. So now I need to do more investigation. So the next thing you check is what? You check ACTH level. You want to know if the hypercortisolism is due to what? Is due to ACTH or not. Is it ACTH dependent or ACTH independent? So if ACTH level is high, you are dealing with ACTH dependent hypercortisolism. If ACTH is low, then we're dealing with what? ACTH independent. So this allows me narrow down the pathology to what? Two locations and to like the possible location, right, of the tumor. So if it's ACTH independent, it's likely what? That's what like we call it primary. It means the adrenal cortex. So it's going to be what? Either the adrenal gland, an adrenal tumor, right? Adrenal gland. That's where the pathology is. Either an adrenal adenoma or hyperplasia. So the adrenal gland is the one making cortisol, and that's why ACTH is suppressed. But or it may be exogenous. Patient is abusing steroid. So either way, cortisol is high and is suppressing right ACTH. So the pituitary gland and hypothalamus they are fine. Pathology is not central; it's primary, it's peripheral. But if ACTH is high, it means ACTH is the one that is stimulating the adrenal gland right to make cortisol. So the pathology is central, or it's from a ACTH dependent tumor, something a tumor making ACTH. So where can we find ACTH dependent stimulating secreting tumor? Either we can find it in the pituitary gland, correct? Or you find them where? You find them in the ectopic, right, location. So another organ, right, outside the pituitary gland, which includes what? The lung. So this is where you now have this small cell, right? Lung cancer. Sometimes renal cell carcinoma. They can make ACTH as paraneoplastic, right, syndrome. Supposed to be. So when it comes to, before I go to ACT dependent, so when it comes to these two, how can I tell them apart? Adrenal cortex, or somebody has problem with an adrenal tumor or is exogenous. They can give you, so this is where you now do adrenal imaging. So you do MRI of the adrenal gland, or you do um, MRI or CT scan of the adrenal gland. If I see a mass, a tumor in the adrenal gland, right? So you know it's an adrenal adenoma. If I don't see a mass, but the adrenal blood has increased cortisol, so the venous sampling shows increased cortisol, then you're dealing with maybe adrenal hyperplasia. But if I do MRI or CT scan in somebody taking exogenous steroid, what happens to the adrenal gland? Adrenal gland will undergo what? Atrophy, bilateral atrophy. So this is exogenous, they are using steroid. But if I see a mass or the adrenal gland, both of them are enlarged, there's cortisol in the veins, then it's likely a tumor, adenoma, or hyperplasia. So you can, right? Okay, so now when it comes to these ones, the ACTH dependent, this is one where we do what? High dose DEXA suppression. So you're gonna give the patient high dose dexamethasone. This is when you're gonna do high dose dexamethasone suppression test if you're doing ACTH dependent. Because pituitary gland tumors, they are still going to retain cortisol receptor, right, on their membrane. But because the cells are so much, their number, they cancer cells, right? There's a lot of them. Unlike normal pituitary gland, they're gonna be a lot. So I need higher dose of DEXA, right, to suppress them. And since they have DEXA receptor or cortisol receptor on their membrane, they're gonna respond to high dose DEXA, right? So if you give high dose DEXA in pituitary gland adenoma, there will be, right, ACTH will now go down. You now reach ACTH level, ACTH will go down, and cortisol might decrease also. So the pituitary gland tumor will respond to high dose DEXA. But ectopic tumor, making ACTH, they don't have cortisol receptors. So whether low dose or high dose DEXA, they're not going to respond. So ACTH will still remain high after the high dose DEXA. And this tells me that what the tumor is an ectopic. It's not pituitary gland. It's somewhere else, either in the lung, the kidneys, or something like that. Yeah. And now that I know the location, right, I can now do what? If I know, okay, now this is the pituitary gland, I can do MRI of the egg or the pituitary gland to confirm. Now that I know this one is ectopic, then I can do things like lung, CT or X-ray, or abdominal, right? CT or X-ray if you're looking for renal cell carcinoma. Yeah. So this is the basis for the suppression test. So basically, everybody gets low dose. Anybody with hypercortisolism gets low dose DEXA. The key of giving low dose DEXA is to make sure this is true hypercortisolism. Because if the axis responds to low dose suppression, it's not Cushingism, something else. But if the axis doesn't respond, cortisol remains high after giving low dose, the axis is not responding, then you know there's a pathology right in that axis. Then we usually check ACTH next. We want to determine if it's ACTH dependent or independent because we have different differentials. If it's ACTH independent, then you know that the pituitary and hypothalamus are fine. That's why they are suppressed by cortisol. So the problem was by the adrenal gland making cortisol, like a tumor, adenoma, or hyperplasia, or patient is abusing steroid. Yeah, exogenous steroid use. So you can, if they can give you imaging of the adrenal gland to tell them apart. You see a mass in the adrenal gland, you know it's an adenoma. If you see bilateral adrenal atrophy, patient is actually likely taking steroid, right, from the outside. Then, if ACH is high now, you're dealing with ACH dependent. The pituitary adenoma can do that, or an ectopic tumor making ACTH. So that's why now I will give what high dose DEXA. Since pituitary adenoma will still retain cortisol receptor, they are going to respond to high dose DEXA. So ACTH will go down, cortisol will go down. But in ectopic tumors, lung cells don't have cells in the lung that become cancer. They don't have ACTH cortisol receptor. Renal cells will not have cortisol receptor, even normally. So when they become cancerous, they won't have receptors either. Does that make sense? So they won't respond to high dose DEXA. ACTH will still be high. Also will still be high, and that time, okay, this is an ectopic tumor, and then that will now guide you as to, okay, which image you can get, right, to confirm based on the location, right? Yeah. So this is why those tests are important. You got this?